Hi everyone, I'm Paul, and for the last year and a half I've been working as an anesthetic and ICU registrar in Galway University Hospital on the west coast of Ireland. In this video I want to talk to you about end-of-life care, withdrawal of care and palliative care. I'm not gonna have this talk all by myself because some people, some more experienced people than I am, have accepted my invitation in this interview. So we're going to talk with Dr. Pat Nelligan, who's also a professor here at the University of Galway, and he's an ICU and anesthesia doctor for over 30 years now, so a lot of experience. And with Ann Gatley, who's a very experienced nurse, a very funny one, which I love to work with, and they're going to share with us their opinions on the subjects I've just mentioned. I'm very grateful for them for doing this, and I'm very excited to share this with you. Let's see what this is all about.
We would say to the family, we are going to withdraw life-sustaining therapies because this is wrong, it's unethical, and we're making this patient suffer unnecessarily. If I go and talk to a family, I just say it straight up, your mum or dad is dying. The D word, everybody knows what dying means.
Cardiac cripple, for instance, it's probably the biggest disability one can have, you know, no exercise tolerance.
And you've seen this yourself, you've been here long enough. The nurses will come to you and say, he's not going to survive, this is wrong. And the nurses often start the conversation. And the nurses are continuously talking to the families, and they will often start the conversations with the families. And they're very, very skilled at it.
Most unselfish thing to do for a relative is stand outside and think what you'd want, and then look at them and think, no, this isn't about me, as much as I'll miss them and as much as I'll, you know, grieve them.
It's a hard feeling.
It's a very difficult thing to do.
Yeah. People are, the way the world works, you're kind of forced into making a rapid decision on something, and sometimes you're not in a position to do that. Yeah. And so I say, I'm not comfortable making that decision because I don't have enough information, and I need to process this, and I need to spend time thinking about this. Because there's a whole problem of sunk costs where people make a decision, they feel, oh no, I have to go with that because I've made that decision. I don't want to lose face. I don't want to have reputational damage, and it's called status quo bias.
When you give such news to a family, how do you feel about it?
Oh, I'm very sad for a family. You can always empathise because, you know...
Because I feel sad.
I feel so sad.
And I get it, I don't know how it's called, you know?
A lump in your throat.
A lump in your throat, yeah.
And I sometimes, it's obvious by me.
But to me, I can't imagine a situation where you have people in a hospital ICU bed for weeks or months who clearly can't survive. It's torture, it's horrific, it's the wrong thing to do to somebody. I can't imagine that happening to a member of my family.
Do you have an age criteria for admission?
No.
Yeah, they have in England. I'm not sure about the age criteria.
Yeah.
And of course, when you're in the ICU, every day is it's like dog years. You know, every day is like a month. You're aging at an alarming rate. Your body is deconditioning. Your organ systems are becoming malfunctional. So after about 4 weeks, your chances of surviving are extremely low.
But I feel, as a nurse, you can prepare relatives for the worst. You can say to them, it's worrying. I am worried about it.
And sometimes I do it myself. I just get attached to a patient, and I find it hard to let go. Yeah. You know, and luckily somebody comes in and says, no, you're mad, you know.
And I say that, and that's one of the first things I do. Patient settled. I go out and I speak with the relatives, and I say to them, I think the relatives deserve care as well. And I say, you know, he has come in, he's quite sick, but he's stable, he's in the right place. But we are probably going to be about a half an hour.
What's the policy here? I don't know exactly.
Well, my policy is within reason, whenever. As nobody will stop me.
Is there a written policy?
ICU doctors don't get sued. Anesthetists get sued a lot. In Ireland, we have a very aggressive legal profession who are just looking for cases. But families don't sue ICU doctors or ICU nurses, and there's a good reason for that. Our first wave of COVID, nobody died in our ICU because we didn't get overwhelmed, and we actually gave the patient a lot of time to recover. Yeah, we were making that decision, but the problem we had is that we needed to make sure that young people had beds in the ICU. In most health systems, nobody really thinks of the doctors and the nurses in the ICU. They think of this as a ward over there somewhere where really sick people go, but we're not like cardiologists or gastroenterologists that have all glamorous lifestyles and we drive massive cars and have huge houses.
Yeah. So this is one of the facts that I liked the most here like people like you who have a lot of experience,
Yeah.
you're not afraid to admit, I don't know, I was wrong.
For myself, I want to get paid so I can have a decent living and my kids can grow up in a safe place. That's why I live in the west of Ireland. It's a safe place. The weather's terrible, but they have great schools. There's good restaurants. We've good nightlife and stuff.
End of life, end of life. No, I just said what I thought. End of life, definitely. Do not resuscitate. You can't deliver care unless you have hope.
Yeah.
You know, it's like, does the patient hear you? You'd like to think not, but you have to believe they do.
Yeah.
And especially on DNARs, end-of-life care.
Right.
And was that always here?
No.
Because we don't have that back home.
Yeah, so
you cannot stop, especially withdrawal of care. We
Right.
see sometimes here.
Yeah, so no, it wasn't.
No, it wasn't.
Well, we. So, no. It's hard to explain this to you.
How did it all start?
Well, it always was, but
Okay.
it wasn't. In other words, we never had formal do not resuscitation orders in Ireland. We never did. In America, they did. So when I went to America, we had to do this, every patient, every day. But you have to remember, in Ireland, the only person who has a relationship with the doctor is the patient themselves. We don't have any surrogacy laws. So if you're in the ICU, for example, your partner cannot make decisions for you officially under our law. Now, you can for your child, but not any other way. So our system is always paternalistic. So, for example, if we decided that a patient could not survive critical illness, we would say to the family, we are going to withdraw life-sustaining therapies because this is wrong, it's unethical, and we're making this patient suffer unnecessarily. And this is not the way it should be. And most Irish people, when they hear, if I say, for example, your mother or father is dying and we are prolonging their suffering, they would say, that's fine. We don't have to have their permission, but we like to have their blessing.
And it's still...
And well, it's always been like that. So even with forms, yeah, absolutely. So we have forms here, but those forms are irrelevant. All it does is quantify what we've already done or always did. So in the UK and in Ireland, and it's culturally extremely similar, it's slightly paternalistic, but also I think it's highly ethical that we don't keep people alive unnecessarily.
And what happens if the family says no, do whatever it takes for them, even if they have 0.1%.
But they don't. It's very. I rarely have ever encountered this. I've heard of this.
Okay.
I have never personally encountered this because I generally find that if I talk to the families myself, they understand. Because if you talk to people as if they were members of your own family and explain it to you, that while we really would like to see our mum or our dad live forever, everybody dies, and this unfortunately we've done everything to try and keep them alive, but there is no possibility of them surviving, and everybody is suffering. I think most people understand that. I think if you really make an effort to communicate, and one of the problems I have with a lot of doctors is they're afraid to actually be fairly blunt, right? One of the words we have is that, if I go and talk to a family, I just say it straight up, your mum or dad is dying. The D word, everybody knows what dying means. Sometimes you have people, and they come up with these euphemisms. Euphemism is basically an alternative word to dress up something. So they'll say, he's not doing very well, the prognosis is grave, and this kind of stuff. And people go, what is he talking about? Just speak standard language. And what people understand is that they're going to die. And if you're really honest with people, they understand that. So I've never encountered this. I never encountered this problem in America. I never encountered it here. Having said that, I've seen this problem with other people. And so in America, what would happen is the lawyers would get involved. And that was a nightmare. Now, we do have a hospital ethics committee here. And if there is a conflict between what the family want and the doctors want, again, remembering the doctors can pull out at any time, but we don't want to do that if the family really feel very strongly about it. We can call in the ethics committee and there can be a discussion. And then they can make an adjudication. But I have no respect for this because I'm an intensive care specialist. They're not. They don't understand my business. And we will often, in our practice, if there's an issue, we'll just get 2 or 3 of the ICU doctors to talk to the family, and maybe we'll all meet together. I'd rather do it that way.
Yeah.
And certainly in America, they've gone to court and all this kind of stuff.
But I'm taking everything in comparison to what we have home. And for example, we don't have palliative care, and we don't have end-of-life care, and there's no such thing as withdrawal care. So you obviously have a lot of experience, and you've seen a lot of deaths as well. Because death, let's face it, it's a common thing in an ICU.
Yeah.
And we have to face it that I was talking the other day with Dr. Nelligan, and he said 15% mortality rate in the ICU, in this ICU.
15, yeah.
15. So how do you see that? Like, I'm not going to ask you a specific question about it.
Yeah.
Just let me know.
I have a very strong opinion on that.
Yeah.
And I've had this opinion for many years. I think everybody should have a living will.
A living will as in?
A living will as in you clearly, concisely say, should I wake up with a deficit as in frontal brain damage, personality change, I do not wish to be resuscitated, you know, or should it be impending that I'll wake up with it. And I think everybody should be educated on that level. And I think the sooner we have medical solicitors, the better. That will sit down and explain, you know, if you get a head injury or if you have an out-of-hospital cardiac arrest, yes, you be resuscitated, but you know, you may have other organs that may encounter problems, but you may also wake up with brain damage. There may be ways of telling from scans, etc. Would you want to live like that? Well, I think everybody should be educated. And I don't think there's enough education. Media, social media.
Yeah. I think there's certain cases where you'd say, no, I don't want to. Like, if I'm paralyzed from neck down, you would say, I don't want to live anymore. Or if I'm brain damaged, yeah, that's definitely, it's not a gray zone. But there's a lot of gray zone in this area as well.
Well, you know, people are cleverer than we realize. You know, when you speak with some relatives, you know, you have 5 or 6 relatives, you'll have one relative that will say to you, he wouldn't want to live like this.
Yeah.
You know, he wouldn't want to live blind. He wouldn't want to live, I know him very well. But the rest of the family don't want to think about that because they don't want to be the ones. Whereas if he has that written somewhere. And another thing I think that we should all be bound to carry, now I'm sure my organs are no good at this stage, but we should all be bound to carry an organ donor card. It should be an opt-out actually, rather than an opt-in.
Yeah,
and I think there are 2 things in ICU that I would love during my time in ICU. I would like to be more, you know, prevalent, but I'm afraid it didn't.
And so you get these sick patients. You can clearly see they're in organ failure, multiple organ failure, and there's a very, very low chance of surviving. And even if they survive, the burden they have to suffer afterwards is immense. It's a lot, and that's
reduces the quality of life.
Yeah, that's you can't say life is not just laying in bed, getting fed to a tube.
It's not.
And not being
it's not quantity, it's quality.
It's quality, yeah. So at that point, I seen here the nurses start talking to the family, just getting them in, and then the consultants arrive and explain the situation to the family. And most of the families I've seen, they accept. And
you have to
they trust people. They trust. I think it's a matter of trust.
But you have to kind of sometimes step in before they start their thought process by saying, "Oh, if he were to have a deficit, if he were to have a personality change, if he were to have no quality of life, if he were to never be cardiac crippled, for instance, it's probably the biggest disability one can have, you know, no exercise tolerance." And if you can, you know, prompt the relatives to think about that before the hour comes when somebody says to them, a doctor says to them, well, we probably can get him over this, but, and then, you know, they have had that thought process, and then they would say, well, he wouldn't want to live like that. And you know, and you actually, I always say to people, the most unselfish thing to do for a relative is stand outside and think what you'd want, and then look at them and think, no, this isn't about me, as much as I'll miss them and as much as I'll, you know, grieve them.
It's a hard feeling.
It's a very difficult thing to do. Yeah.
For the family to say, okay, you can stop.
But they should never, ever, ever, no family should be faced with the question.
Yeah.
They should be faced with, like, when you speak with relatives, you know, some doctors do say to them, do you think, would you like if we did? They should never have to make that decision. In our experience, you know, the outcome of this is going to be limitations of life, of mobility, of whatever.
Or futility, or because you might be doing all for nothing because the patient might die.
Absolutely.
3 days, a week, 2 or 4 weeks.
And you can sometimes say to them, you know, we can sustain your relative for another 4 or 5 days, who knows, maybe 6 or 7 days, but the outcome will still be the same. Whereas he hasn't enjoyed that 6 or 7 days, even though, and certainly you won't enjoy looking at them. So I think that there should be more. Now it is a good unit for that.
Yeah.
It is good.
So we don't have that back home, and obviously you need to have a lot of experience to call that, isn't it?
Absolutely.
Say, look, this person is not going to survive. You know what I mean?
Yeah. And you've seen this yourself, you've been here long enough. The nurses will come to you and say, he's not going to survive, this is wrong. And the nurses often start the conversation. And the nurses are continuously talking to the families, and they will often start the conversations with the families. And they're very, very skilled at it.
I think it's a slippery slope you get yourself into, in the sense that you might be wrong sometimes, you know?
Yeah.
You might say, no, this person is not going to survive, but there's things that you don't know. So, for example, myself, when I'm on call in the ICU, I abstain on saying anything like this because I feel I lack experience.
Yeah, you do.
To say that, you know.
But that's why I'm paid. That's why I'm paid to be a consultant there.
So that's why even if I'm 99% sure this person is not going to survive, I'm not going. Maybe I'll say there's little chances to survive, you know. But I'm not going to make a definitive. You know, this person. I wouldn't say this person is dying.
Right.
And I think you need a lot of experience.
You certainly do.
To say that,
and
do that.
you know, occasionally I've been bullied into having a family meeting. But if there's a lot of pushback from the family, I'll go, okay, I take your point. If I haven't, I have this kind of rule: I never have a family meeting on a Monday because I just don't know the patients that well. And I don't want to end up in the situation where the nurses are pushing an end-of-life discussion, and I'm not comfortable myself because I just don't know the patient and I haven't been there for a few weeks. And so I like to spend a lot of time with the patient and see what's going on. And you know, I'll take my time coming to that decision, and sometimes I'll make a decision about it, and then I'll go and do a thing called a pre-mortem, which means I look a week into the future and say, well, what if I made the wrong decision? And then I come back to it later on. So I'll often say, people will be hassling me to make an end-of-life decision. I say, I'm going for a cup of coffee. I'm going to think about this and I'll come back and talk to you later. One of the big problems is people are, the way the world works, you're kind of forced into making a rapid decision on something. And sometimes you're not in a position to do that. And so I say, I'm not comfortable making that decision because I don't have enough information and I need to process this and I need to spend time thinking about this. And so absolutely, I don't think I've ever regretted an end-of-life decision when it happened. But I've had a couple, maybe 2 that I remember, where I was kind of forced into having an end-of-life discussion with the family and the patient walked out of the hospital. Happened twice.
How did that make you feel?
Well, you see, but at the same time, the patient walked out of the hospital because I did not withdraw life support. I listened to the family and then I spent a lot of time with the patient and went, they're right. And one thing as a doctor, you have to be willing to say, hey, you're right and I'm wrong. I made a mistake, no problem. I have no problem saying that a decision that I made yesterday was the wrong decision and I'm completely changing it. Because there's a whole problem of sunk costs where people make a decision, they feel, oh no, I have to go with that because I've made that decision. I don't want to lose face. I don't want to have a reputational damage. And it's called status quo bias. And my view is, I spent a lot of time thinking. One of my obsessions about 6 or 7 years ago was to look at how we think and how we function. And the first thing that you have to accept is that you're going to make a lot of bad decisions. You always do. You can't not. It's the way the world works. The thing is, you need to recognize that you've made bad decisions and then reverse them. Again, I don't think I've ever made any I've never withdrawn at somebody who didn't pass away very quickly, because I'd say nearly all of these, no, all of them really, realistically, where you get to the point of withdrawal of life-sustaining therapies, that it's really obvious to everybody.
Do you have an age criteria for admission?
No.
Yeah, they have in England. I'm not sure about the age criteria.
Yeah, that's a discussion there.
And I've always felt like that.
Yeah.
Now, I don't think, 95, when the three nuts come off the car wheel, the fourth one is going to come off. So, I think at that stage, I think that they're...
I think age shouldn't be...
No, I don't think age should be a criteria. I think comorbidities should.
Things that come with age, yes.
Plus, disease outcomes and all the... they'll all have... they'll all have a myopathy post... whatever the drugs, post the bed rest, post the illness.
People don't see that, People imagine patients in ICU are kept at home, in your own bed, and nothing happens. But you lose 14% in a couple of days of your muscle mass. In just a couple of days of an ICU stay, because you're not moving at all. And then you get steroids and all the drugs that we give to people.
Absolutely, neuromuscular blockers. They're the
blockers for ventilation. And then you get all these associated diseases with the ICU, and people don't see that. And I think it's reasonable. Because if you don't know, you assume things, You assume, okay, they might be like that.
But very often the myopathy is reversible.
Yeah.
We all have to live with the fact that you may lose a percentage of your your independence, whatever, but when it's life-changing.
Recovery after that.
With
comorbidities and recovery after that.
And we will never be in a position to assess a home situation to see how many people are there to support, and
because once a patient is out of the ICU, it's not over with their
it's neither the time or it's not relevant at the time when they're in to say, well, if he does survive this with the deficit, many people are at home to hoist him in and out of bed, or many people are at home to
And when you give such news to a family, how do you feel about it?
I'm very sad for a family. You can always empathise because
Because I feel sad.
I feel so sad, and
I get it. I don't know how it's called.
A lump in your throat.
A lump in your throat. Yeah.
And I sometimes, it's obvious by me. I sometimes have to we had a period for a few years where we had lots of young people in road traffic accidents.
Yeah.
And you'd go out and sit with a doctor having had scans, and they're waiting for the results of the scans, and they wait to see if they're going to Beaumont, and the boat has sailed. They've coned, or they're about to, they have the cerebral edema, and oh my God, I feel, and even if you don't empathise with your own family or friends, you don't want that pain yourself, so you know what it's like.
Yeah.
And I don't think it's any harm, but I think sometimes it can be very difficult not to show it.
Yeah, I know.
So.
And have you ever had someone that completely refused the withdrawal treatment?
Oh yeah, we have had. Yeah.
What happens then? What happens when the family is not on board and when they say, no, we want to do everything you can for this?
Oh, we frequently would have that.
Yeah. And what happens?
We had one case, And again, family wanted to do everything, quite aggressive. You see, we've got a high traveller community here, you know, and they will care for their relatives in whatever they live. But that was one of them actually. But nature took its course in the end. Well, I'd say we had slight withdrawal, but nothing aggressive. So it was all very gentle, you know. But we've had people who, you know, they write down what the pumps are on.
Yeah.
They might not know which pump is which, but that was on 5. Why is it on 2 now? Okay. That was on. Why is it off? So, you know, and you just say.
But having said that, all
majority.
The patients here get, at one point, get maximum care.
Oh yeah,
you know?
Absolutely.
Like, I've never seen a patient come here and say, no chances, no.
No, every patient.
Like, even when we withdraw care, you withdraw care after at least hours, if not tens of hours.
It's very humane, very humane.
Like you give everyone a chance, but then when you see nothing changes or nothing improves with the treatment you offer.
Do you think we initiate palliative care quick enough though?
I'd say we kind of
I don't think we do
enough.
Here now. I don't think we do.
That might be a good
And we're all
thing.
guilty of it.
It might be a good thing, just in a sense. You never know when someone can change its course, especially in the gray zone area with patients that.
Well, you know, some palliative care doesn't mean, you know, that they're, you know, that it's, you know, it's the outcome is definitely death.
Yeah.
But like we've had people like who've had amputations and they have phantom limbs, and palliative care are enormous in what they contribute to that.
But to me, I can't imagine a situation where you have people in a hospital ICU bed for weeks or months who clearly can't survive. It's torture. It's horrific. It's the wrong thing to do to somebody. I can't imagine that happening to a member of my family. You know, it's horrendous, because it's a totally unnatural situation. And of course, when you're in the ICU, every day is like dog years. You know, every day is like a month. You're aging at an alarming rate. Your body is deconditioning. Your organ systems are becoming malfunctional. So after about 4 weeks, your chances of surviving are extremely low. If you're sitting,
I think that's what people that I work with in Romania, actually patients or families don't understand that. They think that we can keep them alive for 1 or 2 months and then they'll get back to how they were before, but that's never the case.
Yeah, it can't be the case, You know? And that's why it's important that you have really good nurses who are able to communicate.
I think communication is key.
Yeah,
you know,
it's all communication. And, you know, and people get cognitive dissonance, right? I mean, we all want our family member to make a quick recovery. And it's important that healthcare providers are honest with people. There is nothing worse than a consultant coming into the ICU and saying, oh, he's fine.
Yeah.
You go, no, he's not. He's in the ICU. He's critically ill. And we had this situation once upon a time where we'd have a cancer doctor come in and say, well, if he gets chemotherapy, he has a 50% chance of surviving. So we want you to keep the patient alive. And I go, but he's critically ill, and he's only a 5% chance of surviving critical illness. So you're saying he's a 50% chance of 5%, but in fact it's lower than that, because that 5% person has hardly any organs working and won't tolerate chemotherapy at the end of it. So everybody has this problem of cognitive dissonance, and it's difficult, you know, and we struggle with it all the time. Everybody struggles with it.
So you don't actually have a law that makes you able to withdraw care?
There's no law one way or the other.
And so what happens if you withdraw care, you get the family on board, and then they change their mind? What happens if they want to take this to court, you know?
Well, it doesn't really happen.
You killed our father.
So
because
that doesn't happen in Ireland.
There's a recent scandal in Romania where 17 patients have died in 4 days in an ICU.
Right, that's a lot.
The doctors were accused of lowering the NORAD dose on patients. But actually, when they've done the investigation, 4 patients were out of hospital cardiac arrest. They were very ill, sick patients. 2 patients were brought from other
Yeah.
hospitals that they couldn't care for them anymore. So.
But I think you have to be really careful.
We were accused of murders.
Yeah, but then you have to be really,
Senseless.
really careful of this stuff because, for example, I am very aggressive in the ICU about being pragmatic. And a few of my colleagues are like that. When we go into the ICU, we institute end of life on patients who, when we've had a couple of days, realize have no chance of surviving. But I may follow 3 weeks of people who couldn't make a decision on this. And so suddenly it may look like the 5 patients died in 3 days when I was here.
Yeah, exactly.
But that's because they didn't die last week or the week before. And there's a whole thing called regression to the mean. 15% of patients die. And so it's just, once you understand the mechanism, but when people start making accusations, it's really difficult.
Yeah.
Obviously, we'd be very concerned about the Lucy Ledby story in the UK, where there's a huge increase in mortality in that ICU where babies never died. So if you look at a neonatal ICU, very few babies ever die. But suddenly if you have 20 babies die.
What was the story?
The story was that this was a neonatal ICU in the UK, and they had, over a couple of years, I can't remember, 20 babies died, maybe fewer, maybe more. And it was a lot. I mean, maybe 3 babies died a year in this unit, and suddenly there was a huge increase in babies dying. And eventually they figured out that one of the nurses was killing the babies. But of course, it was easy to prove statistically because there was this huge increase and all the deaths happened when she was physically there. Whereas in our ICU, you'll see some weeks nobody dies, some weeks 5 people die. But over the course of the year, the same number of people always die because that's how it works. But it's difficult because clearly there are some doctors who are better at making decisions than others. And sometimes I do it myself. I just get attached to a patient, and I find it hard to let go. And luckily somebody comes in and says, "No, you're mad." And I go, "But I really like that patient, and I like the family." And you start and then you start behaving strangely yourself. You start losing it, and this happens to all of us. And if any doctor says it never happens to them, they're not telling you the truth because we spend a lot of time talking. But I can tell you, I do 2 jobs: I do anesthesia and I do intensive care. I know I will never be sued as an ICU doctor. ICU doctors don't get sued. Anesthetists get sued a lot. In Ireland, we have a very aggressive legal profession who are just looking for cases. But families don't sue ICU doctors or ICU nurses, and there's a good reason for that. We spend so much time talking to them and communicating with them and explaining things to them because we have time because we're there at the bedside all day long. Yeah, that's what it is. Yeah, and remember, okay, and we have a problem, obviously, that people read all kinds of disinformation on Twitter and Facebook and various other social media platforms. And I find a lot of the time now I'm talking to families, I'm trying to get rid of disinformation. I mean, we had a lot of this during COVID, and that was tough, and it was hard to manage because there was a disinformation going on in the medical profession. People were reading stuff on the internet, wanting to introduce it, and I'm going, no, we follow an evidence-based medicine paradigm. We don't do anything differently than we always did. Our outcomes are better than any outcomes anywhere on the planet. Our first wave of COVID, nobody died in our ICU because we didn't get overwhelmed, and we actually gave the patient a lot of time to recover. And we just did what we always did, managing patients that had severe pneumonia, not some weird disease that needed anti-malarial drugs and drugs for, parasites and all this other weird stuff that came out. And there was things like, don't humidify the ventilator circuit. We went, that's ridiculous, we're not doing that, But those strange things happened. And it is a real challenge if you're a doctor that people can Google anything, they can learn more about the disease than you know very quickly.
During COVID times, if you got like a 85-year-old patient with very bad pneumonia, would you limit the care very fast or? Because our ICU, I was just a beginner back then, but I've seen like a lot of old patients that spent like weeks in the ICU, and I think that was the problem. We got overcrowded very quickly, and I think that was one of the issues.
Yeah, well, I think COVID was an exceptional time and people had to make very difficult decisions. I think most people, I don't know. We didn't have people dying in our ICU. People died in the wards who had multiple comorbidities and just weren't fit to go to critical care.
But that's the reason.
Yeah.
You wouldn't have admitted them in the first
No.
place.
If there was no chance of them surviving, they never got there.
So
And we weren't making
everyone.
we weren't making that decision. But the problem we had is that we needed to make sure that young people had beds in the ICU. Yeah, but we felt good about ourselves at the end of it because we thought we'd done a great job. Frankly, it was what we were trained to do. We felt like, wow, this is a great opportunity for us in our lifetime to prove the value of intensive care and show the world that we actually make a difference. Because in most health systems, nobody really thinks of the doctors and the nurses in the ICU. They think of this as a ward over there somewhere where really sick people go. But we're not like cardiologists or gastroenterologists that have all glamorous lifestyles and we drive massive cars and have huge houses, or surgeons that have kind of names over beds. We're just almost unidentifiable people who just go about doing their jobs and don't have big egos, and we work as a team. We're fairly humble people. You'll never meet a really arrogant ICU doctor. You can't, because you can't be arrogant, because every day you have to come and say, that was a really stupid decision I made yesterday. Let's move on. Whereas you can have a dermatologist, the most arrogant person you ever met, because they're never wrong, because they don't have as much skin in the game, literally, as we do.
Yeah. So this is one of the facts I liked the most here. Like people like you who have a lot of experience.
Yeah.
You're not afraid to admit, I don't know, I was wrong.
Yeah.
Like we don't quite get that back home.
Yeah.
Like people are and because public opinion expects the best out of the doctors, out of the ICU and staff and everything. And they don't accept mistakes. They don't accept people who say, I'm wrong. So then the doctors become impoverished, not impoverished, burdened with the fact
expectation.
That I need to live up to the expectation. I cannot say I'm wrong. Not even to the trainee, I'm wrong, or I don't know, or else I lose all my credibility.
Right, but when I was in training, every doctor I ever encountered was exactly like that.
Okay.
This is, and I think that's a problem because it puts up barriers.
And I thought beginning anesthesia, I thought these doctors are like, oh my God, they know everything. They know everything and they have a solution to everything.
But
and
they're
never wrong, but they don't. And I came here and I've seen brilliant people as well saying, I don't know.
Yeah, but that's confident. But we have tremendous confidence in ourselves, right?
Yeah.
I mean, you can't say you're wrong unless you're confident that most of the time you're not wrong. But my job is for patients. I'm not here for myself. For myself, I want to get paid so I can have a decent living and my kids can grow up in a safe place. That's why I live in the west of Ireland. It's a safe place. The weather's terrible, but they have great schools. There's good restaurants. We've good nightlife and stuff. And it's lovely in the summer when the sun actually shines. We can travel around Europe fairly inexpensively, but it's a safe place to live where they're not going to get executed in their schools. That's all I want from myself. But I'm here for my patients when I'm a doctor. And as a doctor, I have to be the best I can be. And part of being the best you can be is to be honest with yourself that you don't know everything. And there's things you knew 10 years ago that you don't still know because you've forgotten them. And that if people ask you difficult questions, the right thing to do is instead of giving them a line of rubbish, that you say, I don't know this, but I'm going to go read about this. You read about it. We'll come back tomorrow and we'll compare notes. I'll probably have remembered what I used to know about it by then, and maybe what I used to know was wrong. And I have no problem doing that. And I can tell you, I have a few colleagues who are phenomenal people who know more than anybody about everything to do with anesthesia and critical care will say the same. I just can't retain that amount of information. And when I'm making decisions, it's often 50-50. As long as it's not a life-ending decision, sometimes will I start an antibiotic, will I not? Is this the right one, is it not?
Yeah, I can see the
these are, do I give a fluid bolus or do I give a diuretic? Sometimes you don't know. It's because there's a lot of unknowns. Yeah. And it's one of those things I always say, this Donald Rumsfeld. Do you remember Donald Rumsfeld? Probably too young for that. He was the Secretary of Defense in America around the time of the war in Afghanistan. Okay. And he came on TV and everyone ridiculed him for this. And he said, there are things we know that we know. There are things we know we don't know. But we're worried about the things we don't know that we don't know, the unknown unknowns. I thought it was the most genius thing I ever heard in my life. Everybody ridiculed him for it. And I thought, no, he's right. We have this in medicine all the time. we have these unknown unknowns going on because there's things we can measure and things we can't measure. There's only a certain amount of medical knowledge, and there's a lot of stuff that we will know in 30 years' time we don't know now. I mean, if you look at cancer therapy 30 years ago, everyone died. Now most people live. When I graduated medical school, Freddie Mercury, got AIDS and died. A couple of years later, Magic Johnson got HIV, and he's still alive. Certain things we didn't, move on. And my point is that, at this moment in time, we know a lot more than we did 30 years ago, but there's still a lot of unknown unknowns. And you have to accept that you may not be able to make a diagnosis today because you just don't know enough. You don't really understand what's going on.
I can see that in younger doctors back home as well. They're more open to discussion and to admit that they don't know something.
And they're right, and that's really refreshing for me.
Yeah.
And also, I find, particularly in anesthesia, people kind of get stuck in very early into a way of doing things, and I go, stop. Just do something differently, So what I do as an anaesthetist, every year or two, I say, I'm going to do everything completely different than I used to do it. We had a great fellow here called Bob Concannon, who retired maybe 2 years ago, and he was not a young man when he retired. And he'd turn up every day I give a lecture, and he'd be there asking me questions and writing notes. This guy had already retired when he was still going to my lectures, and he was working in the private sector. Yeah. And he'd say, I was at this conference in 1968 or something, and I heard this guy saying, and you're the first person I've ever heard referring to that talk. And I was going, this is amazing, this guy's so interested, and he's still learning. And even though he's at the very end of his career, he knows that what he learns today, he can apply tomorrow to his patients. And then even when he's fully retired, he can come back and talk to our trainees. So you never stop learning, and you can never assume that what you know is correct. And I'm pretty sure half of what I know right now is wrong.
End of life. No, I just said what I thought. End of life, definitely. Do not resuscitate. I do think that we should all, I know my husband doesn't want me, but I know my husband won't make that decision for me. He won't. And I said that to him, I'll launch you.
Yeah, it's hard. Like, as you said, you never should inflict this decision to someone.
Oh, no, you should never make relatives feel they have to make the decision. It's, oh my God. Oh, no. Like in our...
You have that in the back of your mind for the rest of your life.
Mm-hmm. But you do know, I actually think that it's even higher than 15% mortality. I know that, recently we talked about that. I know that when patients come in, but, you look after them because you have seen people who are sicker. Yeah. Respond, maybe not recover 100%, but recover with quality of life. So you have seen it, and you can't deliver care unless you have hope. Yeah. It's like, does the patient hear you? You'd like to think not, but you have to believe they do.
Yeah, I've seen that you always talk to them when you do things.
Yeah. But I don't believe they do, but at the same time, I think.
What did they do?
Oh my God, they hear me swear. They do. But yeah.
So, thank you very much for doing this.
You're very welcome.
Yeah.
I hope it's some benefit, Paul. It won't be any good.
It will.
No, I don't think so. Oh, here's your little.
Yeah.
Your device.